Welcome, everyone. Thank you for joining us this evening for our webinar brought to you by SGIM Health Equity Commission in collaboration with Geriatrics Commission. Our webinar is titled COVID-19 at the intersection of aging and health disparities. And today's webinar is is one of the series of webinars that is sponsored by SGIM Health Equity Commission. The Health Equity Commission serves as SGIM Chief Advocate for health equity related interests, and it seeks to promote, educate, and collaborate with SGIM members and beyond to dismantle structural inequities in health and optimize the outcome of each patient provider encounter, and to pursue social justice, especially for vulnerable and marginalized population. They have a full year of webinar. There has been several webinars in the past that if you visit the SGIM webpage, you should be able to access the recordings, and they have several upcoming webinars that we would like to invite you to join in for. If you're already not a member of SGIM, we would like to encourage you to consider joining. SGIM offers a lifelong learning community, a road to professional advancement, and is a voice for the future of healthcare. SGIM also has a wonderful resource for COVID-19, including a series of members profile called Frontliners. Please visit the SGIM website for these exciting area and resources. Now on to today's webinar. My name is Shahla Baharlou. I'm an associate professor at Department of Geriatrics and Palliative Medicine at Icahn School of Medicine at Mount Sinai in New York. I'm joined in by three of my wonderful colleagues, Dr. Hollis D, who is the Chief of Geriatrics at Boston Medical Center and Chief Section for Geriatrics and in Department of Medicine, as well as Lee Lindquist, who is a Section Chief for Geriatrics in the Department of Medicine and Associate Professor of Medicine in Northwestern University Feinberg School of Medicine in Chicago. And Dr. Lexi Torek, who's an Associate Professor of Medicine and Associate Division Chief of General Internal Medicine and Geriatrics in Indiana University and Indiana School of Medicine. We are going to talk to you about disparities that has brought up in various settings for older adults with COVID-19 and ethical issues related to that. The order of talks would be Inpatient by Hollis D, and Nursing Home Issues by Lee Lindquist, Outpatient by myself, and Ethical Issues by Lexi Torek. With that, I'll ask Dr. Hollis D to start her talk. I'm sorry, before we start up, I wanted to make sure everyone is muted, and please hold on to your question and write it in your chat. We will have a dedicated 30 minutes for question and answers at the end, and we will look forward to an interaction and a great session with you. Thank you. Hollis?
Great. Well, thank you all for having us. We were very excited to be able to partner with the Health Equities Commission around this particular topic, which is near and dear to my heart. Not only do I serve as Chief of Geriatrics, but for my hospitalist colleagues, I am also our inpatient director, and so have seen the impact of COVID on older adults in many different forms. Next slide, please. I wouldn't be a good general internist if I didn't start off with a story or a patient case. And so I want to share with you actually two patients, both of whom sort of collided on the same day, but I'm calling them Mrs. P and Mrs. V, the common thread. It was, of course, on a Friday afternoon, because these things always happen on a Friday afternoon, that I got a call from our nurse practitioner in practice about one of my primary care patients. She had recently, Mrs. P, had recently been discharged from the hospital with COVID, and the nurse practitioner was calling to make a follow-up call. She talked to the patient's daughter, and her daughter said, well, she's doing fairly well. Okay, what does that mean? Well, at rest, she's on oxygen, about 2 liters, but every time she gets up to walk, her oxygen saturation goes down to about 85%. Okay, then I put her oxygen up to 4 to 5 liters and she's back up to 94%. With some degree of concern, the nurse practitioner said, don't you think that maybe you should bring your mom back to the hospital? And the daughter said, no, she doesn't want to come back. So the NP called me. I called the daughter and she said, Dr. Day, you know my mother. She's very stubborn. She doesn't want to come back. Her mother also does not speak English. And I said, well, is your mom there? No, she's resting at the moment. I said, all right, I'm going to call her back in just a little bit so that we can all talk. I said, I will support your decision, but I want you to understand I am quite concerned. I hang up the phone. The residents look over at me and they're like, wow, that sounded pretty tough. I said, yeah, it is. It was hard enough getting her into the hospital in the first place. And now she doesn't want to go back. In the meantime, on that team, Mrs. V was downstairs. Mrs. V was in her 90s, quite demented and quite delirious. Over the course of her hospitalization, which occurred because she had fractured her hip and had surgery, she also had been in the hospital. And like many of our patients, there is no visitation policy. As such, she stopped taking her medications, including her apixaban and her metoprolol, and her heart rate was now 150 and stayed there for quite some time. Despite multiple FaceTime conversations with her daughter and trying to get her to take her medications, she consistently refused, requiring IV medications and a transfer to the IMCU, which had not previously been needed. So what's the common thread? Well, it has to do with what happened to these patients in the hospital. Next slide. Well, let me just take a step back. First of all, why should we care about this? Why should we care about age, and why should we care about the inpatient status? Well, as it turns out, of 8 out of 10 deaths from coronavirus, that is 80%, have been in patients over the age of 65. Next slide. Compared to patients aged 18 to 29, if you are 65 to 74, you have a 5 times higher chance of being hospitalized and a 90 times chance higher of dying. If you are age 85 or higher, however, you have a 13 times chance of being hospitalized from COVID and 630 times higher chance of dying. 630 times. I don't know, that statistic really struck me, and it's hard to wrap your head around. Next slide. Now, let me be very clear about this. We know that this is not just about older patients. And we know that there are significant racial disparities in COVID mortality. If you look at COVID deaths, just the actual rate, there have been considerable disparities and differences between Pacific Islanders, the Latino population, Black, Indigenous peoples, white, and Asian. And if you adjust for age and you are non-white and non-Asian, you're almost 2 times as likely to become infected and 4 times as likely to be hospitalized and almost 3 times as likely to die from COVID. And one of the things about this, the importance about the age adjusted, is there aren't as many people often of other ethnic backgrounds as there are white patients in those higher age categories. So it appears that a disproportionate number of older white adults are dying, but in fact, it's just because there are more of them. So the age-adjusted rate is very important. Next slide. So what's really the problem then? If we know the why and why we should care, what is really the problem? Well, delirium is one of the biggest issues. And for a reminder of those who maybe haven't brushed up on their delirium definition recently, that it's an acute onset, waxing and waning, inattention, disorganized thinking, and an altered level of consciousness. Delirium disproportionately affects older adults. And pre-COVID, 1/3 of patients over the age of 70 admitted to medicine get delirious. Half of those are delirious on admission and the other half develop it. So that's already a lot of people that we're talking about. Delirium itself, aside from everything else that's going on, is independently associated with a risk of death, about 1.5 to 2.5 times, depending on the study that you look at. So what about the mortality rate at the intersection of COVID and delirium? Well, it turns out that depending on the studies that you look at, just those two things alone, your mortality rate is somewhere between 30 and 75%, and averaging across studies at about 50%. And one of the things about this is that delirium is a very common problem, a very common presenting aspect of COVID. And unfortunately, the CDC does not recognize this as one of those checklist symptoms for COVID presentation. And about 40% of older adults will present to the ED with clear chest x-rays, but delirium, and are COVID positive. So unfortunately, we may not even be capturing all of the people coming in, at least initially, that have COVID. And up until the time now, with routine testing, that was a real problem in the spring. Next slide. So really, what's the problem then? Well, delirium equals a change from baseline. And with our hospital policies of no visitation, then how do we know that this is a change from baseline? If there's no family there, we can't know. Delirium is waxing and waning. So when we have patients trying to FaceTime with their family members, that's usually when they're doing well and not when they're not doing so well. And it may not capture the changes. Next, isolation policies, staff staying in the room the least amount of time. Patients can't easily get their sensory aids like hearing aids or glasses. They can't mobilize easily. And the isolation from that actually leads to people feeling more disoriented and less able to figure out where they are and getting sicker. Treatment for delirium requires frequent reorientation, sensory input, mobility. Treatment requires people. And here's the kicker. You can say, well, no visitation, that policy applies to everybody. But this is where age actually really is different. If you can't see or you can't hear and you only recognize your family, then we cannot expect our patients to adhere to treatment, nutrition, eating, or trust in the system. Add into that language barriers and maybe some historic mistrust of the system, and it's just not the same as it is for a younger person. And no matter how well you explain it to families, particularly those that already have reasons to mistrust the system, they have a terrible difficulty understanding what's going on with their patient, with their parents, their mother or their father, and can't understand why they're not getting better and why they seem so confused and why it's taking so long for them to get out of the hospital. Next slide, please. So I'm not just going to list what all the problems are, of course, but I think we really need to be thoughtful about how we address this problem, specifically for our older adults, because this is a disparity that falls on them more so than our other population. First of all, I think we really need to think about appropriately permissive visitation policies. If someone is already cognitively impaired and they are dependent on a family member. With appropriate testing, PPE, whatever it is, we should be able to allow the family member to come in, help reorient them, help them with their basic activities of daily living, mobility, getting their sensory aids, whatever that may be, to help address the delirium issue and potentially get the patient better faster. Secondly, we need to think about better use of technology for reorientation. I don't know about you, but not everybody goes into our whiteboards and changes the day and changes what the day of the week is on the handwritten board, particularly in the COVID rooms. So how can we use technology better? Not only for reorientation, but how can we use it, for example, for family pictures to share so that patients know where they are? What about therapeutic activities that we could actually provide for patients to help prevent delirium before they come in? How can we better deploy our volunteers? For example, calling our patients and talking to them in their native language, perhaps. Making sure that we have walkers and canes in the room so that patients can more comfortably get up and don't have to ask for those things. Making sure that we are actually putting the shades down at night and opening them during the day, even in that brief interval that we go in. Just making sure that we're really paying attention, especially for our older patients. Next slide. So let me tell you the common thread. I called Mrs. P back that night. I had the interpreter on the phone and she said, "Doc, I'm not coming into the hospital." Okay, Mrs. P, why not? She said, "When I was in the hospital, all I did was lie there by myself. I couldn't hear what people were saying. I couldn't see. I couldn't talk to my family. They didn't do anything. If I'm gonna die, then I'm gonna die at home with my family, and I'm not coming back to the hospital." Mrs. V ultimately got out of her delirium after many, many days, but her daughter was completely mistrusting that the nurses were doing the best that they could, even though we could see that they were trying so hard to get her to take her medication. She was concerned because her mother lost weight during the hospitalization, and even now when she's been transferred to subacute, which Lee is going to talk about in just a moment, she can only see her through the window of the first floor. She said, "Mom looks thinner to me and I'm still worried about her because I can't see what's going on." And Mrs. V cannot understand why her daughter cannot come to see her. Next slide. So I'm just going to close by saying, remembering that age is a number, not an ability. That when we are thinking about policies that disproportionately affect certain groups, we actually need to think about impact on older adults who may be more frail and perhaps have less ability. Next slide. I would encourage us to think about this quote from Ashton Applewhite, that ageism is actually a prejudice against our own future selves, and that if we are going to have future pandemics and future problems on the inpatient setting, we actually need to think about policies more specifically around older adults, not just those who are at end of life, but those who have delirium, who are at risk. And I would encourage us all to be involved in that particular set of policy development. And now, since my patients went to long-term care, I'm going to turn it over to Lee for long-term care as well.
Hello, everybody, and thanks for tuning in. That was a great talk, Hollis, and a great lead-in, because many of our hospitalized patients end up coming to long-term care facilities, and that's what I'll be talking about. These are two of my favorite seniors. These are my grandparents, and let's talk about keeping them safe. Next slide. So quick blurb, Northwestern Geriatrics. This is our team. So we're a small team, all women attendings. And in 2020, 6 of these people had exposures to or quarantines from COVID, and 4 of us had repeats. I was a repeat. I have antibodies. I had COVID. So it's something when you look at a picture of all your colleagues, this is something that was affecting all of us. And we're all working in the nursing homes. Next slide. And so the SNFs experience, or the skilled nursing facilities experienced the first COVID outbreaks. And our first COVID outbreak here in Chicago was March 10th. And we had actually closed our doors March 7th, which was prior to CMS, which was March 13th. And what we've seen over and over again in the long-term care arena is that CMS and the public health departments have dragged behind what we need for change. And so when I closed the doors, or when we closed the doors at the skilled nursing facility that I go to, it was several days before even the first SNF patient had COVID. But we knew it was coming. We knew it was going to be bad from what we saw in Washington state. So I had a lot of pushback. I had a lot of pushback from families who wanted to sneak in still. I had physicians who had parents there who still wanted to sneak in. And so we said, nope, we're closing our doors. And as you can see, there was a definite lag time before CMS came out with policies. Next slide. So when we think about the skilled nursing facility and COVID, this was a Sisyphean effort. So admissions across the country, I know in New York, they had the same problem, that skilled nursing facilities were given state orders early on that we had to accept all patients, even those that are COVID-19 positive. And most of the skilled nursing facilities at that time had lacked PPE and also isolation units. So we had to accept COVID-19 patients that were potentially positive still, because we didn't know much about it at the time. And then when we look at testing, the skilled nursing facilities were supposed to, at least for Illinois, contact our Illinois Department of Public Health with a possible case. And then our Department of Public Health would provide us with would not provide us with the swab or collection equipment. So you had to find a swab. Okay, think about how simple that is. And this is so crazy that I am downtown Chicago and we are literally looking for a swab somewhere to stick up somebody's nose. And this was happening across the country to the places I talked to in New York and San Francisco and in Washington. What we were instructed to do is if we found a swab, we could swab and then we'd actually have to drive it to the lab and get the results in 3 to 5 days later. And then the IDPH, also our Department of Public Health, recommended that we send all positive patients to the emergency room. And you know yourself, our skilled nursing facilities and long-term care facilities are filled with 100-year-olds and 90-year-olds who are not in love with leaving to go to the hospital. And what we were told is that we should either take a patient to the drive-through for testing for retest or forcibly remove the patient and transfer them to the ED. I am not joking you. This is ridiculous. And I did not talk to those people for a while because of the ridiculousness on these. And so for the most part, we ended up treating in place as a presumed positive and then ultimately going to hospice. And what was frustrating was that the numbers were coming out and we knew that they were dramatically undercounted for what we were experiencing in the skilled nursing facility. In Chicago at our worst was about a 35% positivity rate, but I'd say easily in our nursing homes, we were up to about 50%. Next slide. So these are the nursing homes that we go to. And the one that I am medical director at is the pretty one on the top left. It's a high rise because we're here in Chicago, 53 stories. And so you can imagine how quickly COVID would spread. Next slide. So those look beautiful, but this is what they ended up becoming. So we found that a lot of our patients at the beginning were dying without testing. So we had patients that were critical, passed away, went to hospice without testing, without what we considered presumed positive. And what really irked me was that I had so many patients that had lived through COVID and were now developing isolation issues. And these are the same isolation issues that Hollis was talking about earlier. We see a lot of depression. I've seen patients lose 20 pounds in the last 8 months, a lot more agitation. And then subsequently, I've had so many patients end up going to the next level care of death. Next slide. So we've already finished our first round of vaccinations and our second round of vaccinations. And we are currently in day 330 of isolation. Can you imagine that? Can you imagine if one of the prisoners was to spend 330 days in isolation? And so that's why I showed a picture. Here's a prison cell and here is a long-term care facility nursing home room. And so it is room only, there's no roaming. And we're on day 330. And so Even with second round vaccinations going out, our public health department has not let us know if we will be able to release our seniors to roam a little bit or, get visitors in. So we're not able to have visitors inside. There's no socialization in person. And this is what we're experiencing still. So next slide. So that doesn't mean we don't care. We're all trying our hardest. And this is what I feel like sometimes it's the forgotten frontier or forgotten front line, whichever one you want to use. So in our building, we did not have a isolation unit. So everyone had to come up with what I feel like is almost a third world country isolation feeling, because we literally had to close down a room, get an HVAC, HEPA filter, and pour it out of the window. Bear in mind, this is Chicago and we're in the 20s right now. So that room is very cold. And so it's been, that's kind of how the rooms are set up. And it's an area that we can shrink back and forth. On top of that, we didn't have enough PPE. So our group was smart, and the people that I work with at this nursing home, they actually went to Menards and ordered PPE, which was the goggles and raincoats from Menards, of all places. So that's the ingenuity that we're dealing with. To cut down on the isolation, we're totally open to ideas, and our nutritionist actually had the idea that we could have group meals by putting everybody on a call with each other. So during dinner times, people will actually have Zoom calls with their TV monitors to kind of try to get people to still be in contact with each other. And then we'll put people by the doors and have name that tune, where a person will walk up and down the hallway singing songs. So there's still people who are trying hard to keep people and to work against this isolation, because this is day 330 of never leaving your room. And if you think about yourselves, everybody on this call has probably left their room maybe once, I'm hoping, in the last 330 days. But this is something that we would probably not expect any other age group other than our seniors to do, which is just painful on so many levels. So there are people that are caring. I'm glad to see people on this webinar who are listening to this. And next slide. So I want to thank you guys, and I will pass it on to the excellent Shahla Baharlou.
Thank you, Lee. And thank you, Hollis. So now to outpatient and challenges that we had with outpatient in regard to these patients that Hollis took care of in inpatient and Lee took care of them in nursing homes. Next slide, please. So we were lucky to be able to start with telehealth and public health emergency allowed CMS to, kind of promote the access to telehealth, both audio and virtual telehealth, which was a lifesaver and a really wonderful service that had been pretty much not used over many years. Most of our institution and our, I guess, electronic medical record did not have the setup for that. So the pandemic, in a way, actually promoted this. This was one of the good aspects of the pandemic. However, this was different, for older adults. The adaptation to telehealth, as we have seen, has been much slower for older patients. Mostly because of inability to have the access to technology. There are a good number of patients who still have a flip phone, and they use their landlines, and they don't have a virtual access. A ton of patients have limited access to their internet, even in New York City, surprisingly. As you know, I think personally, you might have experienced connecting to virtual visits within most EMR has been quite clunky and requires many steps that most older adults are unable to go through. I think this is more, we see that this is much more highlighted in patients. Not only old, but also patients who have low socioeconomic status and people of color who have less access to these technologies. And one of the things I think that we encountered early on, especially during the shutdown, was that many of these older adults on their own were not able to do this. And because of shutdown, they were actually left alone, and they couldn't do the access. But they were so happy if they were able to even connect to us by phone. Even the audio portion of it was really helpful for them to feel less isolated. I think the isolation has been one of the biggest challenges that older adults have had in the outpatient community. Next slide, please. So as you know, the telehealth that has been approved by CMS during public health emergency has two ways or two portions, either telephone or audio only versus telehealth. And as you may have experienced, the audio only or telephone visits are pretty much limited, both for providers and for patients. When you connect to patients virtually and you're able to see where they are, there is some of that connection of face-to-face. I saw this, and I'm sure you have experienced it. A lot of patients who were locked in, they were so happy to see me, even on a video. So, and they felt like they are getting connected. They're not as isolated. And it took away some of the stress associated with the pandemic. As you have experienced, we could do, a lot of portions of virtual physical exam. As a geriatrician, we do cognitive assessment, we do depression screening, we do anxiety screening. A ton of our psychology or psychiatry colleagues do virtual visits now, up until now, and they're exclusively doing all their visits virtually. So those things could be done. The other part that we have been able to do virtually, which has been quite helpful, is seeing a patient walk, looking at their gait, looking at how the home is set up. Some of my patients have been able to walk around with their, phone or with their tablets and show me how things are set up, or they have their wife or husband or partner hold the phone and they're able to walk, and I could see, I could assess the safety of the house or safety of the apartment. They could show me the medication that they have gotten. So there's a lot of advantage to having a virtual visit. To add to this, CMS was also paying much less for the audio visit, which would limit, both, promoting that for patients and for providers. That seems to have changed, and there's a bit of a good news in there. Next slide, please. So this slide actually shows you the outpatient payment for virtual visits on top, which is really much based on CMS rules. They're pretty similar to in-person visit. And you could compare that with the telephone visits at the bottom of your screen, 99441, 99442, and 99443. For audio visits, their RVUs and the payment were much more limited, between $14 to $40 from spending 5 to 10 minutes to 21 to 30 minutes with the patient. Compare that with, the amount of even the lowest established patients of 76 to the highest level of 211. That seems to have changed. Can you please do the next slide? So CMS has announced that they're actually reimbursing and they're matching the audio visit to similar in-person visit. So they're increasing the payment from 14 to 41 to now to 60 to 137, which is really great. And they retroactively doing this to March 1st of 2020. I think this is helpful both for patients and providers. And it will allow basically, leveling the care for patients who have access to audio only. I think for the policy aspect of this, we have to think about this, that this is going to be only for, duration of the duration of the public health emergency. And this is not something that will stay on. We're hoping that most of these telehealth and telephone visits would be a portion of our work for the future, because I think we have found that this is actually super helpful for people who have limited access in transportation, people who are homebound. This been super helpful in doing various urgent visits, and it allows patients to connect to their providers at the comfort of their own home without worrying about many of these issues. This has not been as easy for patients with dementia, patients with cognitive impairment, and those are the group that have, I think, most of the issues with this change in pace and their adaptation to what's going on during pandemic has not been easy. And that's something that we have to keep in mind. A lot of our patients, and as I'm sure you have experiences, a lot of older patients with cognitive impairment do need a caregiver with them who could help out with any type of connection, whether it's audio or virtual visit. And I think their sense of knowing that there's someone that they will be talking to, it is not as it's not as easy for them as someone who is cognitively intact. So something to keep in mind. Next slide, please. There are other broader social effects of COVID pandemic for older adults. When we shut down in March and April, this basically interrupted home care for patients. Ton of our patients are dependent on their home health aid, and there were basically, I think, families were faced by the choice of either allowing the aides to come in and potentially bring in COVID pandemic with them, because these home health aides they were essential workers, they used public transportation, and they were at risk. And for many of these patients, the home health aide did not live with them. We noticed people who were in higher socioeconomic status, they were able to change the status of their aide to 24 hours, pay for that, and basically they moved in with the patient, they stayed with the patient. But oftentimes, people who had people of color and people of lower socioeconomic are patients who had few hours of aid. The family had to choose between leaving those folks, letting the aid go and or moving in with the patient to take care of them. During the pandemic, and I still believe this is an issue, there is a limitation of a skilled care to patients' home. We have used, all of us, we have used VNA or VNS. The skilled care, inpatient that we provide as for in-person's home, a lot of those actually turned out to be virtual. So imagine people who did not have virtual connection, they basically were deprived from getting that. That include even some of the hospice nursing visits. A lot of home senior homes for patients that they used as daycare. They went in for either meal or for some activities. They got closed up, and they are still closed up. So that adds to the isolation. A good portion of patients who were receiving free meal delivery within each state, they had interruption of their meal, and that definitely impacted the patients with low socioeconomic and low income older adults. There was and has been increased isolation and mental health issues in patients with dementia. And I think also more as equally important are the physical impact of the pandemic and being isolated in homes, in their homes. Patients are unable to go out, or they're afraid of going out and interacting and being active. And there's a good portion of them that have lost a lot of muscle masses. Next slide, please. I think this slide is to highlight more of what Hollis and Lee were talking about. Really, the COVID death has impacted people who are 75 and above, more so even in 85 and above. Therefore, when we're talking about or thinking about prevention of COVID, and hopefully finding some ways to limit COVID infection, including vaccination, we really need to think about these patients in the age group of 75 and above. Next slide, please. So there are, a lot of barriers to vaccinations. One of the things is that there is this online registration only. It's a complicated and lengthy process. It does need online access or someone, for you, on behalf of you, to do this. Next slide, please. It is an unfair competition because most states, for whatever reason, they expanded eligibility within a day or so from 75 and above to others. And they included 65 and above and essential workers in there. And this created the competition for older adults with the larger pool of, internet savvy, people who could easily take all those spots. And as we know, the people of color are definitely underrepresented in vaccinated polls so far. And I think at this point, we have no plan for homebound older adults. Pretty much most states have no current plan. There is talk about mobile vaccination units, but we really have to think about those things and plan for that. We need to use churches. We need to think about, places like local senior centers to really be able to, catch, have a good catchment area for these patients who need the vaccine most than anyone else. Next, and I think, thank you. Let us know with any question, and I'm going to let Lexi please talk about ethical issues related to COVID.
Thank you. There's been so much rich information in these presentations, and I'm going to try to bring it together by highlighting a few ethical themes that I think kind of cut across these presentations. I want to start also by saying that I think one of the things that has really resonated with me as I've listened to these presentations is the amount of suffering and distress that patients, families, and providers have all felt as a result of the COVID pandemic. I think there's a combination of distress of all kinds, but also some moral distress about the difficult decisions we've had to make in terms of the treatment and prevention of COVID-19. And I'm going to highlight a few of those issues that I think are causing us moral distress. Next slide. So I'm going to focus on 3 ethical issues. So the ethical implications of isolation in the nursing home and hospital, disparities in access to care, and barriers to vaccination. So next slide. So as many of you know who've studied bioethics, we have a basic framework that we use in most of our patient care. And in certainly American bioethics within the last 50 years or so, we particularly preference individual patient characteristics that include respect for autonomy and respect for the individual patient's best interests. One of the most challenging things we face when we think about a pandemic is that we use public health ethics rather than our usual framework, and we kind of turn individual autonomy-focused ethics on its head. So we tend to focus more on justice. What is fair? What is a fair distribution of limited resources? And then we often focus on utilitarian ethics, where we consider things like the greatest good for the greatest number rather than what an individual patient may want. So an increased focus on justice and utilitarian ethics, and a decreased focus on individual autonomy and individual best interests. And I think this really leads to some conundrums that we face together. So I think some examples where you have seen this have been in, for example, isolation in the SNF. Why did we isolate so quickly? It was to prevent spread to other patients. What has the outcome been of that isolation? It's been terribly difficult for the patients who are there. It's been terribly difficult for those who cannot reach out to friends and family. And so in an effort to stop the spread of COVID, we've instituted some policies which actually are particularly painful for older adults. And so I think that isolation in the nursing home and hospital has been an example of where something we put in place to help stop the spread of the pandemic has actually been terribly painful in both the SNF and the hospital setting to our particular patients, and has disproportionately affected older adults. If you go on to the next slide, I think a challenge is that our effort to perhaps stop the spread of the pandemic has had disparate effects for older adults. There are at least 3 other issues where disparities have been an impact, have been an outcome of the pandemic that have been mentioned so far in this presentation, and one is internet access. I remember early in my career when I was learning about health disparities, I heard an example of treatment of breast cancer as an example where there really were very few disparities by race until effective treatments for breast cancer came along. And those effective treatments were disproportionately given to white women. And so a disparity was actually worsened by an available technology. And internet access, I think, is an example of this, where the presence of this technology has actually worsened disparities because people who are wealthy, who are younger, or who are white have tended to have more access to the internet. And therefore, a technology that we think of as a good thing actually has the unintended negative consequence of widening disparities. And this internet access disparity has actually affected at least 2 aspects of COVID treatment, which are the access to virtual visits and the access to registration for vaccinations, because it's been pointed out that vaccination registration is primarily done online. So it has disproportionately affected older adults and people of color. And I think this is a huge problem, with our healthcare system. A second issue that I think has been particularly important for older adults has been the ability to self-advocate. And I think that there are at least 2 areas where this has been particularly important: is power in the health system, which again is disproportionately held by white people compared to people of color, and is also impaired by a problem that affects older adults more than younger adults, which is cognitive impairment. So for example, to be able to advocate for oneself in the inpatient setting, to say, I need something hasn't been brought to me, I'd like to speak to a patient advocate, is going to be impaired by cognitive function. Power in the healthcare system, again, is going to be disproportionately held by people who are white and people who are higher up in the socioeconomic system. And something that someone else related, I think it was Lee, mentioning that physicians, often want to sneak in and visit their family members. My mother has been admitted to the hospital twice since the COVID pandemic started. I was faced with a personal ethical challenge of, do I sneak in to see her? Is that fair? I mean, all these other patients can't have their family members there, but I've got my badge, so I could go up to this Explorer and find my mom and make sure she's doing okay. Is that okay? You know, it's a difference between being fair and being equitable versus doing what I know how to do best, which is advocate within the health system, you know, because I am a physician. A third thing I want to point to is mistrust and racism in healthcare, which has led to a lack of access to primary care and to delay of care, which I think are exacerbated in the healthcare system. And I think Hollis, you know, told a very poignant story of a patient who simply did not want to come back to the hospital after she'd been in the hospital once. And, you know, as many of us who cared for COVID patients know, a common pattern is to have a bout of illness, to go home, and then to decline again. That is something that many of us have seen. And to have had such a bad experience that we don't want to come back to the hospital is a double tragedy. I want to talk about this difference. I think this graph was really helpful to me, which is a difference between equality and equity, where equality is giving everybody the same thing and equity is giving everyone what they need. And this experience of isolation that older adults have experienced, in which they are disproportionately affected, particularly by delirium, I think points out this difference between equality and equity. You can put all of our patients in an isolation room, and people who are younger or people who have more access to technology and more socioeconomic resources will have their iPad, will be able to navigate those things. And so equity is providing each patient with what they need, not providing each patient with the same thing. And again, another inequality or inequity that has been magnified. Next slide. I want to talk about a really interesting challenge that we face in terms of vaccination requirements by age versus by other factors such as comorbidity. And this is an area where I think sometimes managing disparities of ageism versus racism becomes very challenging. So Hollis pointed to this. If we look at the figure entitled Limitations by Age, I think that you can see that if you look at the older ages, the boomers and the silent and the greatest generation, you can see that those older adults make up 22% and 8% of the overall population, but a much lower proportion of minorities. And so as you can see, people who age to be older adults tend to disproportionately be white. And that is because of health equities that they experience over the course of their lifetime. And is because of comorbidities such as obesity, diabetes, hypertension, and stroke, which disproportionately affect people of color. Hollis already showed these series of graphs on the right, and this is just another version of it. But as you can see, if you look at graphs that are unadjusted to age, it looks like COVID proportionately affects people of different races and ethnicities. But if you look at age standardized graphs, you see that in fact, white people are more likely to survive COVID versus African Americans and Hispanic people. And that is, you know, because of the disproportionate effect of comorbidities. So what is the problem here? The problem is that if we allocate vaccinations entirely based on age, we are vaccinating more white people than people of color. And we are vaccinating more white people and people of color, despite the fact that younger people who are African American and Latino are at risk of death from COVID. And so this has actually caused me a great deal of anxiety, and I'm glad to see that in Indiana, our age restrictions are lowering fairly quickly, because I think it's very important for people of color in their 50s and 60s who are at high risk of death because of comorbidities. In fact, they're at risk as white people who are 10 or 20 years older should have access to vaccinations. I think this is one place where we're just challenged because age is a really nice, easy way to designate who can get a vaccine and who can't. But this is a problem for equity in our society. And I think this is something that I struggle with and that I think all of us should struggle with. Next slide, please. A final point that I want to make is about the barrier to vaccinations of mistrust of the healthcare system and of vaccinations. And I have seen this, frankly, all across the political spectrum. We have certainly hear about it in the popular press from people on the political right who regard early on the COVID-19 pandemic as a hoax and the vaccination as potentially, potentially a fraud. But I also hear it from many of my patients who've been historically underserved or mistreated by the medical system, including my African-American patients, who really strongly distrust the healthcare system and believe that the vaccination is not going to help them. I struggle with how to counsel them. I was so eager to get the vaccine. I signed, I went and got mine as soon as I could. I signed my parents up as soon as I could with, given my internet savvy, worldview. But I talk to many of my patients who are not having it. And I worry about that because to me, it feels like a health disparity. One of my colleagues at the University of Chicago, Monica Peak, who works a lot on health disparities, describes it as a double tragedy if patients of color refuse to be vaccinated, because after being more likely to suffer from COVID initially, they are more likely to die of COVID because of avoiding the vaccinations. But there's a challenge here, is whether we should consider this difference a difference or a disparity. And I think this graph illustrates that there are some differences in what patients of color want because of differences in patient preferences or clinical needs. But there are other differences that are due to biases, stereotyping, uncertainty, regulatory climate, and also because of a fear of the health system born of past disparities. And I think a difficult question for us is whether we should consider vaccine refusal to be a disparity or a difference. And I would argue that it is a disparity that is born of past discrimination in the healthcare system and really is going to be a double tragedy if our patients of color, our African-American and Latinx patients refuse vaccine on the basis of mistrust. So these are just some of the ethical issues that I have been struggling with. I don't have any easy answers, and I hope our conversation in the next period, just allows us to dig into some of these challenges a little bit more deeply. So thank you.
So thank you, everyone. That was awesome. Great lectures. So I'm going to moderate the questions. One of the great questions we had was, how are you continuing with physical therapy while respecting social isolation rules? So I'll throw it to Hollis, because that's an inpatient and skilled nursing facility perspective.
Yeah, it is. It has been challenging, and I think it has been handled in a number of different ways. And so obviously there are differences between our COVID positive and our non-COVID population. And I think one thing I'd like to point out, at least in our local context, is that right now the hospital's running at about 100% capacity, but the number of COVID patients has gone down. Unfortunately, the number of beds occupied has not. And that means that it just makes it more challenging for the hospital, even on a good day, to run efficiently. And therefore, what we're seeing with our physical therapists is that they are trying, obviously, to see non-COVID patients the most. When they are seeing COVID positive patients, it is often in the context of being outside of the room, and then there's an iPad on the inside that they are guiding the patient through. And the nurses sometimes will be in the room doing whatever the nursing care is and providing assistance to maybe help sit the patient up at the edge of the bed, or follow the physical therapist's guidance. But if someone is quite delirious or quite agitated and not mobilizing, unfortunately, physical therapy has not been able to reach as many people on the COVID floors as possible, particularly those older adults. I think the second issue is the lack of mobility aids always in the room. So every time that there's a mobility aid like a walker that traditionally physical therapy might lend out to a patient during the course of their hospital stay, that then once the patient is discharged or transferred, also has to be decontaminated, and it takes that piece of equipment out of the room or out of utility for a period of time. I think our physical therapists have done the best that they possibly can with it, but I would say that had I thought about the fact that we were going to have a pandemic a year ago, but if I had actually really taken it into consideration, I would have looked at physical therapy and mobility scores pre-pandemic and now, and I suspect there's a very big difference.
Yeah, that's great. I'd say in the skilled nursing facility, one of the biggest problems we've had is actually the physical therapists and the therapists coming out positive. So or positive for COVID. And there's that asymptomatic phase. So we've had a couple physical therapists that were tested. We're doing twice weekly testing for COVID in the nursing homes. So I have gotten a fair share of COVID tests along the way. But they have come back positive, and then we had to test about 30 people on each case, and then we picked up more positives. The physical therapists are actually working in the rooms. They're doing full PPE, and they're seeing the non-COVID patients. And so the non-COVID patients are the ones that are getting the physical therapy. There is a physical therapist that's worked specifically with the COVID positives, and that's a person that now we know has had antibodies, has had COVID, so they had volunteered. But it is very difficult. We're seeing a lot of spread actually through ancillary members. So paid caregivers have come in positive, and then by the time we've gotten the test back, they've actually spread it to the physical therapist, was in one case that we had. And then that caregiver worked with other seniors, and then that physical therapist worked with other seniors. So it was a spread, even though the seniors never left their room. So it is definitely painful. And I'll pass it over to Shahla for how you're dealing with it in the outpatient setting.
In the outpatient, I think it's exactly the same way that you folks have dealt with. We initially during the shutdown, basically everything shut down and we had nothing. And they started, most of these outpatient physical therapists and visiting nurse services, they started as a virtual. But now they have started going into the patient's home, and therefore we have started having calls coming from various physical therapists or VNS to say, your patient has been exposed, our therapist has the infection, and they were seeing the patient a couple of days ago. So I think most often, patients now are, patients and families are challenged now by, they're facing this, difficult decision whether they should wait on getting physical or occupational therapy or even nurse visits, or should they wait until, things are calmed down somehow. Often we see patients are unable, to accept these type of care unless they're really desperate. And we have seen, unfortunately, patients, have the infection contracted from their therapist. So it's really a barrier, and it's a difficult decision for patients and families.
Yeah, great answer. I think that's all the questions. Does anyone else have other questions that they would like to ask? Or just like happy Tuesday?
I think this was great. I'm Ariba Kara. I'm a hospitalist. I do purely inpatient work. And I think what Lexi was talking about, the struggle between doing what's right for an individual patient versus what's right for everybody else, that felt very real. And in March, families were grateful. And by June, families were angry. And that's just been hard to deal with. And I don't know where that falls in the realm of advocacy or policies, or even what that ethical dilemma is. But it felt like the pandemic has felt to me, it just brings great disappointment in the human race sometimes, because it felt like people who were kind and brave will continue to be kind and brave, and people who were entitled were going to continue to act entitled. And it just felt very dark and bad, and I'm just so grateful that there's so many people advocating for the right thing. That was not a question.
Well, I really appreciate that, Aruba, because I understand very much from the inpatient side that, and I think that this holds true for long-term care as well, certainly, is this sense of, okay, you know, I think many of us experience, we got through the first few months of this, and so why can't we go back to being the way it used to be, at least with visitation policies? And there were actually, I don't know if you're your own place, in the summer when the cases kind of went down quite a bit, at least for us, we were able to relax our visitation policy for a bit. So we were able to have family members in from, you know, at a later time in the afternoon, obviously wearing masks, et cetera, and only one person at a time. So it seemed like, okay, this is great. And then we had to shut that down again. And I think one of the things that we've come to with our hospitalist colleagues have really been advocating for not just people who are CMO, because we've actually had families say that they have felt pressured to make someone CMO in order to be able to see them. That was their perception of what we were saying, when in fact that was not the case. But we've relaxed the visitation policy in that if the team thinks somebody is likely to die in the next 2 weeks, then family can come and see them one at a time. But that doesn't help with the underlying cause of the people we don't think are necessarily going to die in the next 2 weeks, but they're delirious and maybe they've had a hip fracture. They have nothing to do with COVID. They're in the hospital for some other reason, and still these policies apply. So it has set up a dynamic between families and the health system, of an adversarial dynamic that is unintended.
Yeah, I think we are lifting our visitation policies, the no visitation policies for non-COVID patients. So glad to see that happening soon.
Yeah, I think just to agree with everything that Hollis has said, I think, and you too, Ariba, I think everyone has had a moment of darkness, whether it's like your 90th patient dying, or not 90th, but, you know, too many patients in 1 week that have been passing away, or just the overall unfairness of it. I mean, from my end right now, I'm irritated that we've got vaccinated residents that can't be visited by family members. And that's frustrating, and they can't even leave with family members right now. But I do think that there's got to be a light at the end of the tunnel, because a year ago, I tried to do telehealth with seniors, or 2 years ago, I tried to do telehealth with seniors, and I was told that seniors can't do it. And at least we've gotten to the point where we're like, hey, we're making headway, we can do it, you know, and we're not like excluded from the party, you know, from a senior perspective, because I think there's so many misconceptions about seniors and their lack of ability, that they're excluded from so many things. And at least we are showing, listen, they can do some level of telehealth. We have to include them. You know, we have to pay attention to the nursing home industry. You know, the flu kills people, COVID kills people, but we need to pay more attention to seniors. So if anything, it's shedding more light on the issues, and it's magnifying it. And I hope more people get angry and change policies, you know? So yeah, I'm always a glass half full type perspective. And I think you kind of have to be in geriatrics, because no offense, all your patients die. It's kind of the natural, and I see Hollis laughing and Alexi, I'm like, it's the normal thing. But I do think that there's better things to come. I'll just say that. Okay, any other questions or comments, or just like everyone loves Shahla's background?
I was going to actually say how you folks are dealing with the vaccination, because I know every state has a different policy. So Lee, tell us maybe how you're doing in the nursing homes.
So yeah, we have I feel like was it North Carolina or Virginia? There was one state that was over there that did really good. But from our standpoint, we have 2 national chains in Chicago. And in the nursing home industry, we were given a choice of 3 days to pick. And then we had 1 day once a month for the vaccinations. And so if you think about trying to get 600 people churned through in 1 day at a nursing home that doesn't do vaccinations, it was a trial, definitely, but we made it through. And I was somewhat disappointed because I thought we had done enough to promote it and to talk to people, but we only had about half of our staff decide to take the vaccine. And that is actually what we're seeing across the board in many skilled nursing facilities, is that there's a lot of disparities in staff not wanting to take it or having misconceptions of it. And so I think that's been the biggest push that we keep on doing. So vaccination in the nursing homes going okay. Vaccinations in assisted and independent living is sporadic. And I really think it's who begged who the most to get them to vaccinate their IL sides, because it's sporadic in most of our facilities. And then as far as patients, so I'm sure, everyone's experiencing this, but it's a free-for-all. And I feel like the seniors that have no offspring or access to electronics are the ones that are really struggling, because the people that have offspring are the ones that are getting in. And the ones that don't are the ones that are still struggling. So we're doing phone outreach, especially among my nurses, but it's ongoing. But I think, Shahla, you in New York, you guys are killing it, or you guys are doing better than us. Not killing it. Oh my God, wrong word to use, joking about COVID. You're doing an excellent job. Sorry, you guys. Not killing it, dude.
That is, I don't know if I say we're killing it, but I think the first day that they opened up the vaccination for all 75 years and older, and actually our hospital started giving as a site. I remember the first floor of the hospital was completely full of patients, and they did not leave after 12 o'clock at night. They stayed there to get their vaccine. So and these were people with walkers, with wheelchairs. It was unreal. You could not imagine how crazy this was. Unfortunately, again, the next day, actually, Cuomo, our governor, opened up the pool to 65 and older, and included, the essential workers that they should be getting the vaccine, but that pretty much pushed 75-year-old and older, to the back of the line again.
Can I clarify? I'm so sorry. I just wanted to make sure I understood correctly that your state, even if just for 1 day, prioritized 75 and older before healthcare workers? No.
So healthcare workers were first, and then
okay.
They started with 75-year to the second. They followed the CDC. Second line were 75 years and older, and then the third line were supposed to be 65 and older, and essential workers, teachers, policemen, firemen. But they basically gave 75-year and older about a day or two. I think that weekend they had started giving, and then by Tuesday, they announced that the 65-year-old and older, they could, join the pool plus essential workers. And that kind of, changed the dynamics. But I think the uptake is pretty good with patients. What I have seen, which I think is really critical for us as healthcare workers, is to really have this conversation with everyone, have the conversation about the effectiveness of the vaccine, talk about the fears of vaccine, and talk about, potential side effects, really being minimal, and effectiveness with everyone in the bus, on the train, with patients caregivers, with patient's daughter, with patient's son. I think this is a conversation that has to happen. And, that's how we see the converters really, this is something that I think it's a big task for us now. I think that's the only way we could, keep this, COVID infection contained. And we see how people have been impacted in our patients group much more significantly.
I just want to address that I think it's interesting that we're from different, all of the four of us who spoke today are from different states and watch different rollouts happen. And this is, the pros and cons of, how policy often happens in the US, which is it's by state. In our state, we started with healthcare providers who provided direct patient care. And so the health system sent out an email. It was to those who actually worked in providing direct patient care. But one of the things I was actually quite proud of is that included the custodial services, the respiratory therapists, the nurses, the doctors, everyone, the PTs, everyone who was in direct contact with patients, who went into patient rooms. And I really was quite proud of that decision. And it was not until several, days to weeks later, I'm not sure exactly how long, but once they started having open appointments, that they extended it to other people who worked in the healthcare system who didn't have direct patient care. And then they started with the oldest old and went down the line from there. And so I think different states did it differently, but yeah, so, and I do think, I really see your point that someone who's actually working from home, who works in finance, should probably be a much lower priority than the person who has to clean the room or empty the trash or deliver the food.
And I would say, actually, I'm going to, that all politics is local, and that politics includes the health system that you work in. And that not all hospitals, even in the same state, roll things out the same way, which has been quite fascinating to see. And I also have been quite proud of our health system. We are the safety net hospital for Boston. And so had, in general, I think a very close eye on the health equity lens about how we rolled out our vaccine, first to our healthcare workers, like Lexi was saying, that, the day that I was one of the last people to get the email, actually, even though I'm on the inpatient service, but I was down there with maintenance guys because they have to go in the room and fix, whatever's going on. And I felt like, that's totally the way that it should be. Other health systems were not quite as good. And there was kind of more of a free-for-all and a lot of distress among even healthcare providers about how it was rolled out. So I think one of the lessons that came out for me, and we've now been advocating, because as Shahla well knows, we have a very large home care program too. And how do you get the vaccine to patients who can't get any place, right? And this is a very finicky little vaccine that you've got 6 hours that from start to finish, you've got to get out there and get it done. And we've been advocating really on the state level with our own health system and at the state level about how to actually localize these efforts even more now that we are trying to roll it out to overcome some of the things Shahla was talking about. A lot of our patients do not have access to internet or the ability, regardless of age, to sign up. So we are trying to make our community outreach a much bigger part of what we're doing while not wasting vaccine, which is, the real kicker to this.
Yeah, I think similarly at my institution, they did have, basically they asked every department to send out people who are, frontliners and inpatient, people who were in direct contact. Definitely outpatient got the, got pushed to the, to later on the list, which made sense. And I think in addition to the custodians and people who really did, food service delivery, people who did, day-to-day work with patients, our students and residents, all the trainees got to do this as, as a priority. I remember seeing, many of students and residents that they received their vaccine, rightfully before they were getting their second vaccine when we as the outpatient provider were getting the first vaccine. I think there is, Rachel, there's some of that, the administrative group that are getting their vaccine now, as the numbers are, the number of people who were supposed to be vaccinated, is dwindling down. But I agree with you. I think actually, I'm not 100% clear how that's being determined. Just before this talk, I was talking to one of the head of social worker who is not, who's below 75, we do still have people who work at 75 and above. And he told me he was not called because his work is essentially all virtual, and he doesn't anticipate that he's going to be called anytime soon. So I think it varies, but I completely understand, your point. I think part of this is that this is left to not only the state to determine this, but also every institution, has its own interpretation of how to, to deliver the vaccine and delegate the vaccine.
Yeah, and I also appreciate, like you're saying, very proud of how things have been handled. And it's so important to, to make sure that our healthcare systems remain up and running, right? So, you think about essential workers in that way, and it's so complicated to think about how to distribute things. And also, like many of you have mentioned, even in our each of our healthcare systems, individuals elect not to get vaccinated. And so then, I'm in possession of this many vaccinations. And so of course I'm going to distribute these vaccinations to anyone that we can, right? You don't want to lose those vaccinations. So it's very interesting. Thank you all so much.
Thank you. And I think this brings up the fact that we do see this. Unfortunately, there are a number of healthcare providers, in each group, not physician, nurses, custodial care providers. They are going to not trust this vaccine. So I think this is so important for us to have this conversation. I can't stop talking to people. I talk to people on the train. I talk to people when they do my temperature check. I think you need to have this conversation at every point. And you could see, and it takes 5 minutes conversation. And when they know you've gotten the 2 vaccine, nothing happened to you, you're still walking, you're waiting for your daughters to get it, you're waiting for your husband to get it. I think that changes the perception of the people. And I think people have more connection when they see this as a personal experience than hearing it on the news and hearing it on reading it on some other places. So I think it really, the onus is on us, to do this.
I think the story that sort of capitalized it for our age group for me, or just captured the whole thing, was on Sunday. I was asked by an older couple, and they said, we've lived a good life, and we have the opportunity to get the vaccine, but we're not sure we should, because other people who are more deserving should probably get it ahead of us.
Oh,
and we are challenged by an ethical dilemma. And I said, there is no ethics in this. I said, you need to get that vaccine, first of all, because that will help the community return to normal, right? That by you getting the vaccine, this will help. Secondly, the hospitals are full. You do not want to go to the hospital. You don't want to need to go to the hospital for this. And you are helping to keep the hospitals less full. And third, COVID is a horrible way to die, and you do not want to go that way. And I think, the more that we can share that with people, that message, who particularly our older adults who are more likely to feel this way, that no, This is about you. For a change, this really, really, really is about you and getting it. And that is the message that we really need to spread amongst our community.
Thank you very much for joining. And thank you everyone for joining us today. And thank you for speaking and to better days with this new vaccine.
And thanks for moderating, and thanks for leading us, Shahla.
Thanks, Shahla.
Bye.
Bye.
Thanks,
Totally
everyone.
fun.
Take
Thank
care.
you. Take care.